Hi everyone, my name is Hargan. I am one of the strategic advisors for the Cannabis and Mental Health and Cannabis and Psychosis projects. I'm very excited to be here with many experts, people with lived experience to chat a bit more about schizophrenia and psychosis and cannabis use and the relation between all of these different facets. Before we get started, just want to start off with a quick land acknowledgement and then hand it over to the panelists to give a brief introduction of themselves. So I'm currently situated in the city of Hamilton, where I study. The city of Hamilton is situated upon the traditional territories of the Erie, the Huron-Wendat, the Haudenosaunee, and the Mississaugas. This land is covered by the Dish with One Spoon Wampum Belt Convent, which was an agreement between the Haudenosaunee and Anishinaabe to share and care for the resources around the Great Lakes. Thank you so much again for tuning in, and I'll pass it off to Dr. Archie to give a brief introduction of themselves and pass it along from there.
Thank you very much, Hargan. Yes, my name is Suzanne Archie, and I am a professor in the Department of Psychiatry and Behavioral Neurosciences at McMaster University. I am a scientific advisor to the Schizophrenia Society of Canada. I'm also chair of the Anti-Black Racism Task Force for the Department of Psychiatry and the Equity, Diversity, and Inclusion Director for Postgraduate Medical Education at McMaster. And as a psychiatrist, I have done research involving psychosis and cannabis, and in particular among Black youth. I'll pass it to Phil.
Great, thanks. Thanks, Suzanne. Yeah, Phil Thibault here. So much like Suzanne, I'm professor of psychiatry here at Dalhousie University in Halifax. So I'm a psychiatrist. I do have a few other hats as well. So I'm director of research here for our Department of Psychiatry at Dalhousie. And also the Dr. Paul Jansen Chair in Psychotic Disorders, which is a research chair. So I'm a clinician and a researcher. And my research area is in early phase psychosis. So I work with youth and young adults, and primarily in comorbid substance use with a significant focus on cannabis use as well. So. And I'm still currently the president of our Canadian Organization of Early Psychosis Program, which is called CCEIB. And Dr. Herman, I guess, if we're passing along.
Thanks, Phil. My name is Yarissa. I am a psychologist at the Center for Addiction and Mental Health, where I head up substance use harm reduction service for folks who have experienced a psychotic episode. My research is in the area of psychosocial interventions for both substance use disorders and psychotic spectrum disorders, mostly those, the comorbidity of the two. And I've had a passion for a very long time of integrative treatment and how to provide best practice care for treating both substance use challenges and psychotic spectrum illnesses concurrently. And I'll pass it over to Josh.
Hello, everybody. My name's Josh Hanlon. I'm the peer support specialist with the Regional Early Intervention in Psychosis team at the North Bay Regional Hospital. We serve the Northeast region of Ontario. As a peer, I'm somebody who has lived experience with mental health issues. And I've also spent the last 15 years working front line in various areas of the mental health system.
Thank you so much, everyone. Really glad that we have such a broad representation from research to the clinical aspect to the lived experience and really direct support aspect as well. I guess where I'd love to maybe get us started, sharing from your experience, whether that be on the clinical side, the research side, or the experience working directly with individuals who experience schizophrenia and psychosis. Can you tell me a bit more about what's going on in your space within schizophrenia and psychosis? What's been happening in 2024, things that are coming up in terms of research, in terms of new clinical approaches, or in terms of supports that are out there? Would love to hear a bit more about what's been on your mind in relation to these topics recently. And maybe we can start with Dr. Archie.
Oh, well, thank you. So in terms of new research, I think Kelly Anderson, who's an epidemiologist, has headed up a really important project looking at sort of medicinal cannabis retail stores, where they're located, and use of mental health services for psychosis in Ontario. So this is a very recently published study in 2023. And just a bit of context. So, legalization in Ontario started in 2018, and physical location stores were available certainly by 2019. And what her research showed was that there was a link between distance of to a retail store and the number of outpatient visits and emergency department visits for psychotic disorders between 2019 and 2020. We did do a study that looked at the immediate short-term effects of cannabis legalization and didn't find anything in the short term, but this study was very interesting because it did show evidence of association between where like very concentrated cannabis retail stores, where they were located in Ontario, and higher service use for treatment of psychosis. So I thought that was a very interesting new study, sort of just another study sort of supporting the link, I guess, between cannabis use and psychosis, and also that younger users, younger users also had higher frequency use and somewhat proximity to non-medicinal or non-medical cannabis retail stores.
Thanks, Dr. Archie. I had a quick follow-up question for you. I'm sure we can spend a whole hour talking about this, but can you briefly kind of summarize what the literature shows about the relationship between cannabis use and psychosis?
Certainly. That the odds ratio for underage cannabis use, and in particular, so people under the age of 19, the risk of an association with cannabis, it can be significant. So it can double the risk, like if a person uses, say, between the ages of 14 and 16, or certainly less than 19 years of age. But it's not just linked to age of cannabis use, it's also linked to the THC content. So THC content of the cannabis used. So for example, 30% or higher products in terms of THC, there's an increased risk. Frequency of use as well. So if someone's using 3 times a week or more, and they're in that underage group, the risk of subsequently developing psychosis, say 4 or 5 years later of frequent use, is associated with psychosis. And we know that if people have a family history of schizophrenia or psychotic disorders, that in combination with these other risk factors also can increase the risk of psychosis. So it's something that youth may not be aware of, but it's very important to communicate this information to young people, and in particular underage users.
Thank you so much, Dr. Archie. I think that was a great summary of a topic that has so much extensive research on its front as well. So really appreciate those insights, as well as the new study around retail stores that you pointed out. I think it's really interesting to see these changes and the studies that are being done post-legalization. I now want to pass it on to any other panelists who maybe want to start sharing a bit more about what's been on their mind related to their work in relation to psychosis, schizophrenia, or any new studies or new policies or types of work that they've noticed.
Well, maybe I'll jump in. Sorry, yourself. So, yeah, I mean, just to follow up with that, I mean, we're here talking about that link between cannabis and psychosis onset or psychosis risk, and Suzanne, I mean, you know, hit the three main ones as well. I mean, just we can't underscore enough the importance of getting the message out there, and significant amount of research has happened globally around this now as well. So, and we've seen that increase in research in the last 5-10 years on you know, the factors that are the highest risk factors. So that is the age of use, right? When people start using, and it's that daily or almost daily use. So the frequency of use and the potency of product as well. And I think we need to consider potency, as that's something that's really quite new, and our group has been studying a lot recently as well. Because I know, Suzanne, you mentioned about 30% as high potency, but a lot of the studies out of the UK are also, you know, when they actually categorize high potency as 10% THC and higher, they're seeing significant increase in the incidence, like the new cases of psychosis coming out, and all the other negative adverse outcomes as well. And what we've seen in Canada post-legalization is that the market share of potency of product has shifted, and that it's normalized to have 20%, 25% higher THC product, right? Where even 5 years ago at legalization, it was below 20%. So that market share has shifted. And I think, you know, we haven't done perhaps a great enough job of getting that information out there about potency of product, right? So, and that also comes with the, you know, how you use the product as well, because vaping and cartridges is generally high potency product anyways, right? So, and I think that's perhaps a message that we still need to work on and getting out there as well. And I'll just put in here, Hargan, as well. So there was a group of us as well that wrote the lower risk cannabis use guidelines for psychosis. And, you know, this is a good sort of public health approach to, okay, what are the lower risk guidelines? And, you know, 11 recommendations in there that cover a lot of what Suzanne's already mentioned as well. So, you know, that is some of the information perhaps that, you know, could be more widely disseminated as well. So I'll let Urissa speak in here as well too. I won't carry on.
Yeah, I agree with what's been said in terms of where we need to be going. And I think we have an increased opportunity to do so. You know, with legalization, clients are at times more aware of what's in their cannabis. So the levels of THC, the levels of CBD. One of the studies that I'm involved with is following clients longitudinally for years and asking questions about the types of cannabis that they're using, the methods of administration, so whether they're smoking or ingesting, and looking at associations between, you know, frequency of use, potency of use, quantities of use, and how they do in treatment. So how they might engage with different services, outcomes, some of their clinical and functional and health outcomes. So following people over time to start to further explore those relationships between cannabis use and getting into details of how and what they're using. And I think, you know, given some of the very early research about potential protective factors of CBD and how little we know about that, I think there's more to be explored there as well. Clinically, I hear clients tell me I'm smoking cannabis, but there's CBD in it, so I'm all good. And I think there can be some misunderstandings there, and a lot more to learn. You know, on that note, clinically, I guess, outside of research, one of the things I'm experiencing is people come in for treatment for individual therapy or to a group, and they can like see a cannabis shop out the window of our group. Or they're walking over to receive care, and there's cannabis use all around. And for folks who are motivated to change their use, clinically sorting through how to work within the environment in such a way that meets folks' needs without causing too many triggers too early on in their change cycle. So some tricky kind of clinical issues I find coming up with legalization as well. and some misinformation or some misunderstanding that I hear, that sometimes people believe if something's legal, it's okay for you. And we know that's not the case with alcohol, and we know that's not the case with cannabis. And so I think some more psychoeducation in this current landscape is also of need.
Thank you so much. I think that those both offer really valuable perspectives on clinically and in terms of research, what are different facets that we're looking into. I have a couple of questions that I'd love to come back to, but I think Josh would love to hear some of your thoughts building on what Dr. Herman mentioned just around this clinical aspect and how the landscape is changing with maybe legalization, more availability, and how you've seen that present with some of the folks that you're helping.
Overall, I think we're at a very interesting time as far as cannabis as a whole topic goes. I think cannabis, marijuana as a whole has a pretty good head start on anything we're trying to provide, because it's been normalized culturally for so long prior to legalization coming in. Now that we've had legalization for a few years, more studies have been able to be conducted, more people have been able to have open discussions and be honest and truthful about their use, different things like that. I think we're finally starting to get some more data and opinions on what it is. A lot of younger people I speak with, they seem to have the idea that it's weed, big deal. And again, to touch on what Dr. Herman was saying, why would the government legalize it if it wasn't okay for me to use? It's a difficult discussion to kind of step around, because they make valid points, but at the same time, you have to realize with anything comes the responsibility, as does like with alcohol or anything for that matter. So I think it's very interesting, and a lot of people aren't always aware of the amount of products that are out there, how fast they're coming, the different ways of ingestion or taking it, the different percentages, THC versus CBD. I think a lot of people are really unaware, and you would probably be pretty hard pressed to find anything much below 19% THC levels in the majority of products sold. So right off the bat, we're higher than you're ever really supposed to be naturally. So I generally, with people I'll speak to when they have arguments in that regard, is they'll say, well, it's a natural thing. It's a plant that grows out of the ground. And it was natural, but then somebody took it and they've propagated it and they've mixed it with another strain, and now they've created something else. So truly, it's no longer natural. It's been messed with.
Yeah, and it's really interesting sometimes that perception of just how weed or cannabis is perceived by since legalization. I think it's certainly been very positive in some respects, but it can certainly impact the way that people look at substances because of that stuff that was taken. And I just wanted to kind of build off of that and go back to Dr. Thibault, what you had mentioned around potency and that really increasing, especially compared to different countries. Just wanted to get some of your perspectives on, firstly, why you think that is, and secondly, as a psychiatrist, how you see that maybe impacting your practice in terms of impacts on mental illness. I think like Dr. Archie talked about, and like you mentioned in the low risk cannabis use guidelines as well, increase in potency can obviously increase the risk for adverse side effects. And so would love to hear some of your thoughts on that perspective.
Yeah, and I'd love to hear everybody else's thoughts on that as well too. So yeah, I mean, look, the potency of product, and Josh, I mean, you're very right. I mean, this is the discussion I have as well, is that yes, it's cannabis, it's a natural product, but it's not the same plant as what it was back in the 60s and 70s. genetic breeding and plant biology, that's driven the potency of product higher and higher. And I say it's, we've seen that market share change and what's available and what's being sold in Canada. But there's also some really good research to show that actually THC percentage has doubled in jurisdictions in the US and in Europe as well, in European countries. So we're not unique to that necessarily. It is more of a global phenomena. But I have to say, our percentages are still quite high, of what's available in the stores. And you're right, Josh, as you go in, I mean, part of what we do is around harm reduction as well. So if somebody's using and wants to use, we're trying to decrease or mitigate any potential risks. And so one thing with product, if you're going to use, let's try something that's a little bit lower THC. So we might actually go on to the websites and say, okay, what kind of products are there that has a lower THC? And you're right, Josh, sometimes it's hard to find something that actually is, below 15%. It's there, but it's hard, right? To find that. And I think that's a bit of an issue for us moving forward. So, I mean, the potency is I think it's a really good education tool that I don't think we've done a good job at. Now, what's driving that? I mean, I talk about market share. I mean, a lot of that is just driving by the commercialism of it, right? I think sometimes when people go in and they, what are they looking for, right? If somebody's looking for the THC psychoactive component like that high, sometimes that's driving it because higher potency can produce that stronger high, right? And it may be a cost benefit is that you can get higher for less product, so therefore it's going to cost less, right? So there's that sort of commercial aspect of it, of what's being sold and price points and things along those lines as well. And it's also sometimes what general public is asking for, is kind of being driven to that as well. But as well, that education is not coming down on the other end of it, saying that, okay, well, that's probably not what we should be doing, because, we haven't seen, back to Doris's comments, we haven't seen that same sort of progression within alcohol. I mean, you're not going to the liquor stores and finding 100%, alcohol. It's just not going to happen, right? So that's part of it. And yes, what we've seen, and I kind of alluded to some of that before, is it does affect clinical practice. It affects some of the those negative outcomes that we're seeing, definitely increasing that risk of psychosis. It's harder with respect to some harm reduction strategies when somebody's been quite used to high potency product and those effects, and so it does bring a lot of potential struggles in there for individuals and their families.
Yeah, and if I just build on what you all have said so far, for centuries, the original weed was about 2% THC and 2% CBD. And, in countries that are close to the equator, where weed just grows, it's basically stayed the same. It's in countries, usually in northern climates, where marijuana has been genetically engineered to grow in low UV light settings. And so this is why the CBD still remains low at 2%, and the THC content keeps rising and rising, because it's easier to grow in northern climates, the THC that's at higher percentages. And so why the CBD, which is cannabidiol, versus THC content, they used to be balanced. And CBD, as I think Hargan or maybe it was Urissa mentioned earlier, that CBD has some antipsychosis properties with it. And so when THC and CBD are more balanced, the risk may be reduced. I don't know, Urissa, if you want to expand on that.
Yeah, thank you. It's such early days research. There does seem to be protective mechanisms of CBD in terms of the risks associated with THC. And in terms of antipsychotic properties, I know there's research being done, I'm not a part of it, but where using pure CBD as a treatment for psychosis. But I think, still early days in terms of evidence around treatment ability and even protectiveness. I think there's lots more to be explored there.
Thank you so much. Sorry, go ahead, Doctor.
No, I was just going to mention on those the trials and Suzanne around CBD using as a adjunctive therapy within psychosis itself. If we apply it, the principles of like it's going to be a therapeutic modality and therefore you need some good randomized controlled trials to examine that. When we last looked at it, I think there was about 6 randomized controlled trials, 6 to 8 that have examined CBD as an adjunct medication. So an add-on medication to current antipsychotics in helping within psychotic disorders and psychotic symptoms, and it's mixed results. Now, that's not to say that we should not continue with that, because I think we should, because out of those randomized controlled trials, I mean, there was a variety of doses of CBD. There's a variety of how that CBD was developed and where it was manufactured, and how it was implemented as well. So it's, there's potential there, but we still need a lot of research in that area.
And I would like to see more research in this area because, there's thinking about CBD as a treatment issue, but also thinking about CBD as a preventative issue. That maybe if, CBD in the cannabis and the THC, looking at, well, when it is more balanced, does cannabis still carry the same risk for psychosis, for addiction, than when you get these extremes in CBD, THC concentrations?
No, absolutely. I think it's so fascinating to see some of the new research that's coming out, especially around CBD. I find that there's often quite a bit of a focus on THC and the harms that can come with cannabis use. But I think, like you all mentioned, rightly so, that there might be benefits that we're not necessarily aware of at this point. And so certainly we'll be very excited to see studies that come out in the future that are able to look into that a bit further, but like Carissa, that you had touched on, and I think others have briefly touched on as well. I did want to shift gears a bit to chat about something that was brought up briefly now, but also earlier in the conversation, just around psychosis and schizophrenia. I think it's been great touching on cannabis use and what the relationship, that has with these, but also just generally wanted to ask, and maybe we can start with you, Josh, based on your experience working and also your lived experience. Psychosis, schizophrenia generally tend to come with a lot of stigma amongst the general public. I know there's been a lot of efforts made in the past couple of years that have really focused on trying to destigmatize these topics, putting out stats that show, for example, people with schizophrenia are less likely to inflict violence than they are to actually get violence inflicted upon them. And so a lot of stigma in the media and out there. And so, Josh, what I'm curious to hear about is, in your work, how would you see some of this playing out? What kind of work do you do to combat the stigma that you see in the community, and any advice that you would have for others that are looking to do the same?
Big question. I think historically, as far as stigma goes, from what I've seen with schizophrenia, is it kind of became the blanket statement, the scapegoat kind of tag to put on anybody that was having any type of mental health concerns, issues outside of maybe that anybody could see themselves, somebody walking down the street that isn't doing well, talking to themselves or something. I think it was heavily confused with multiple personality disorder and all that kind of stuff. So I think in general, there seems to be a lot more information that's been coming out over the last couple of years, at least that I'm seeing working in the hospital and with in outpatient settings. the conversations have gotten bigger. I think like we run some groups to provide. Some of them are with are more client patient centered, but we also do some that are family centered for family education. Um, to provide them with the information, because many families, especially with for early intervention, they're also going through all this for the first time and don't know how to support their loved one or their person. Um, so providing them with that education, because their limited understanding of it. So I think a lot more, I think just having the discussions and providing the knowledge that isn't regularly accessible for people has really been expanding the discussion and helping people kind of open their mind to what it really is, what it is not, and just and that it's there's a spectrum involved more.
I might add, I think, what I see is almost, there's certainly stigma around psychosis and schizophrenia. And then we see this double stigma for folks who have experienced psychosis and are also using substances. Josh, you're reminding me, I was running a family group last night. So for loved ones of individuals who experience psychosis, and, people feeling or expressing concern around, why would my loved ones smoke weed if it's making them unwell? And part of the education that I'm providing is that people aren't using to become unwell. People don't use for no reason. They use because it does something good for them, even if that's in the short term. Now, having a psychotic episode can be obviously incredibly destabilizing. Um, your world changes. And for some folks, when they use cannabis, it's when they're able to connect with their friends. It's when they're able to be creative. It's when they're able to go to sleep. It can help to cope with, symptoms or reduce distress associated with symptoms. So, I still have symptoms, but they might not bother me as much. And again, although a lot of these gains are in the short term, it's important for loved ones and for healthcare professionals and the public to know that people aren't smoking weed to become unwell. And I think that there has to be, I hope there could be increased compassion for folks who are both experiencing psychosis and using substances, including cannabis, that we need to honor that there's function to their use, maybe even before moving to any treatment options around changing that their use.
I
So
think
I do notice
that's
it's like double stigma. Yeah, sorry, Josh, please.
no, that's you. I think that you said that perfectly. I liken it very much to people that smoke cigarettes or drink alcohol. We all know these things are bad for us, but whoever's using it's doing something for them. Whether it's, you know what I mean? Like you're saying, short term gain, long term, you may have some issues, but nobody is using it to choose to be unwell.
Yes, and just to build on that, back in 2015, we did a qualitative study involving young people with the first episode of psychosis from African, Caribbean, and youth and European groups. And what came out from there is that there's institutionalized discrimination and stigma that youth from all three different ethnic groups face when seeking care for, a first episode of psychosis. The youth talked about feeling stigmatized by clinicians, when they went to emergency room, and feeling like they weren't being believed, or feeling like people treated them differently because they suffered with psychosis or schizophrenia. And so I think that educating healthcare providers about psychosis and its experiences, and you know, how people experiencing this would like to be treated by healthcare providers, um, you know, respecting their experiences and listening to some of their concerns and not re-traumatizing them as they, you know, go through the system and accept help. I think those are really important issues that sometimes as healthcare providers we don't talk about enough when we think about stigma.
I think it's so fascinating. I'm currently a medical student at McMaster, and so I remember when we first started learning about taking histories and asking about substance use, you have a very rigid set of questions that you're asking. But I think, like Herman, like you mentioned so rightly, there's various different ways of gathering that kind of information where it's not focused on do you use cannabis or do you not use cannabis, but more so what does the substance do for you, understanding the motivations behind why people use, and I think that really goes a long way in being able to care for them more compassionately than just having a checklist of questions that you're really trying to check off. And I think Dr. Archie put it so well as well, and not re-traumatizing patients when they're exposed to a healthcare setting where they're coming to get support and reach out for services as well. So I think it's been really great to hear some thoughts and perspectives that you folks have added. I'm just wondering, from your perspective as a clinician, as someone with lived experience, or someone that works with people with lived experience, what are some areas in which you think services, whether that be healthcare, other social services, or other people generally in society, can do better to support people either using substances or support people who are experiencing psychosis or schizophrenia?
That's a big question, Hargan. So I think, I mean, it's actually kind of the root of your, how you phrase the question, you know, what are, you know, how do we support? It is that, it's just developing those support systems, right? And having that support and having that support in a non-judgmental way. Substances are out there, substances are being used. Substances can be used in a truly a recreational way without any negative outcomes. But I think we just have to be knowledgeable about and be able to you know, have those flexible systems. So when, you know, that use becomes sort of a negative influence on that individual, either functioning or otherwise, that there is opportunities there to mitigate that, to change that. I know that's a very general comment, but I think that's sort of an overall direction.
Yeah, I'll add to that, you know, I think some of the training that I do with clinicians, and these are clinicians that work in like a schizophrenia division or a psychosis service, but might not have as much training in the area of substance use. And I talk to them about what we call in motivational interviewing the writing reflex. So it's like the desire to write what we perceive as wrong. And if we see that our client is using cannabis and we believe that it's making them unwell, we want to see them stop using, because we come into this profession because we want people to be well. And so what happens is we end up sometimes in a way telling people what to do, prescribing, suggesting, and we know from the research that that doesn't work. When I tell somebody stop using, they're going to then tell me all the reasons why they should use, and then their conviction and the belief that their use is good for them will strengthen. And so when we tell people what to do, and it inherently does the opposite of what we're hoping that it does. And so some of my training with clinicians is around not doing that. But like we had talked about before, getting to know somebody's, you know, function of their use and why they use, and their stage of change, like where they're at in terms of they're motivated to change their use, because it's not a one size fits all in terms of treatment. And I know we might get there a bit later on in the conversation, but I think some of what we can do better as a healthcare system is to meet people where they're at, to not assume to know what's best for anybody, to be curious about people's motives and motivations, and to take a little bit more time with folks, so that we can work with them to meet them where they're at, and walk beside them in their change goals, without kind of engaging in that writing reflex and pushing to have people change.
One way that our research group is trying to address education of youth directly about psychosis and cannabis is through some video games that we have produced, which try to translate knowledge about psychosis and cannabis by having a protagonist, like a high school student, and the player gets to I guess experience what, you know, some of obviously in a simulated way, hearing voices, having anxiety attacks, depression, and also what it's like to seek different services. So the player can have the protagonist go to an early intervention program or go to a family doctor or an addiction service, so that it hopefully will reduce stigma and improve understanding and appreciation of, you know, the impact of mental illness and addictions and those sorts of things. So we're in the process of studying this, and the consortium has actually helped fund this project. So we're appreciative of this. CHR has also helped to fund this project, and we're hoping at some point it'll be available for Canadian Schizophrenia Society, schools, family doctors, addiction services, early intervention programs to have young people, youth, play the video games and use it as an experiential learning about psychosis experiences.
I think that's so exciting, Dr. Archie, because it's very different to experience something, to actually get a sense of what is it like to hear voices, what is it like to experience an anxiety attack and what that looks like. So really excited to see and, you know, learn more about that resource and the outcomes.
Yeah, we're hoping that we had a small pilot with Black youth where we trained undergraduate students about the research involving underage youth, so that they were knowledgeable, but they're youth themselves. So they were then doing tutorials with Black youth where the video games were the sort of the homework assignment. And so during the tutorials, they could talk about Harry, that's the protagonist, his experiences, and ask questions by using Harry as the character, so they could have their personal questions addressed, but without it being like counseling or something like that. And the surprising thing is that, yeah, knowledge was transferred. This is a very small pilot, just with like 10 youth, but there was improvements in their knowledge, and they enjoyed the whole experience. They enjoyed working with the undergraduate students who are youth themselves, and they enjoyed the stories inherent within the video games. Obviously, you know, these video games are paid with research dollars. They're not there to compete with commercial video games, not by any means. But the point is that video games are a great way to provide experiential knowledge about what psychosis experiences can be like, and also to show what the health entering the healthcare system, what it can be like.
Right. No, I think that's so valuable, and I think it really touches on points that Dr. Thibault and Dr. Herman brought up earlier as well, about really the importance of education, like we were talking about with Potency and the need to kind of get some of that information out there, and Dr. Herman just sharing that information as well with clinicians that are maybe not as familiar with cannabis use and how that impacts people with mental health challenges. And so really great to hear about different ways that we're getting the word out there. And I'd also love to give a chance to Josh, maybe to share a bit from your perspective, being in the front lines as someone with lived experience as well, on things that you think can be done better, things that are being done well from what you've seen.
I think right now, from my area, of work. As far as support goes, I'm a very big believer in individualized support. And I just try to go, I think everybody should try to create an open, honest environment for conversation and work through conversation towards, motivational interviewing, things like that. On a broader scale, where I was kind of surprised as far as with cannabis goes, and I feel would be a great support tool, is more information on the packaging itself. Just like they do with tobacco products, and have increased, they even now on the filters of the cigarettes have a warning rather than just on the pack. And even with that, that's gone from like a quarter of the pack to half the pack to 3/4 of the pack. When I look at a lot of packaging for cannabis products, they haven't been allowed to put anything on it to make it fun or inviting, but at the same time, there's a lot of bright colors, a lot of neat writing. The information of the product itself is generally pretty tiny on there. I'm very surprised, and I think it would provide a lot more education, which could be supportive to people if more of these things were on the packages themselves, because there isn't a lot of information just out floating around in the ether of society when it comes to the potential risks.
I love that, Josh. Like just on a cigarette pack, how nicotine cause specific cancers. It could say
Right.
cannabis has an association with psychosis.
Right.
Wow,
It just,
fantastic.
I think just to give us some historical context on there, that actually did exist initially.
Really?
Yeah, so Health Canada has a way of labeling the products, and so there's always a root, and then there's another sort of line underneath that as well. And so initially, in when things came out in 2018, there was a link there on the packaging with respect to cannabis use and psychosis. But when that was revised after a couple of years, and despite lobbying, and so it's more of a generic risk
Yeah.
labeling versus anything specific. So, but that's an avenue where it'd be great to have that back on the packaging. Right?
Yeah.
So. Yeah. And
Yeah,
more details. Yeah.
it's really important because it's the age of onset of psychosis, but it's also, let's suppose you have psychosis, it leads to relapse and more hospitalizations, and there's very good data about this. So the devil's in the details, right? When you generalize it, well, then it applies to nobody, but there are very specific people at risk. They need to know, and that evidence is there. They're very specific on a cigarette package, so yeah.
Yeah, no, it's certainly really interesting to even hear about the change. I wasn't aware that they actually made a change to how it was initially presented, but I think it goes back to what we've touched on throughout the conversation, just the importance of really getting the knowledge and research that we have across to the folks that are using. And I think that sometimes there's a bit of a gap there in terms of the knowledge translation piece. And I think Josh kind of started this conversation and brought it up, but I'm curious, in your day-to-day work that you do and kind of folks that you support, is there something that frustrates you, or are there opportunities that you see where things could change in a way that would make either your work easier or the life of the people that you support better? I know it's another broad question, but we started on the point of packaging and some changes we'd love to see there. So just thought I'd ask, is there anything else that you would like to see change or anything that frustrates you?
I unmuted myself first there, so I think. No, another great question, Hargan, as well. I mean, yeah, we kind of approach this. It's always good to approach these as opportunities. future opportunities. And there are some frustrating things there. And I think moving forward there's a few things. I mean, obviously within that kind of a question as well. I mean, I'll just jump back even just when you talk about supports in this whole sphere and area. But there's also sort of investment and financial supports, for example, research, right? And actually the government did a great job at the beginning, those first 4 or 5 years. They invested a lot of money into research into this particular area. What we haven't seen is that continue. So there is some concern that, we're going to lose some of that specific funding for research in this whole area around cannabis and substance use and psychosis, which would be really unfortunate because we're just getting going, and as you heard, there's so many areas for research, and it'd be nice to see that continue and not falter or have step back, because we need to have that to develop those educational materials and to develop those knowledge translation products to get out to youth and young adults. So that's my one thing I'll put out there, is just around that support. There's opportunities there, and it's not government, but it also could be other organizations and philanthropic foundations that may help. Be nice to kind of support this area as well. I'll stop with that one.
Thanks so much, Dr. Thibault. I'll pass it on to anyone else if they have something to add there, but I think that's a really big one around the support and continuing that instead of in short bursts where you're not really able to see those longitudinal effects that we've touched on previously as well.
I think the government could actually put more resources into education of the public and in particular youth. I think that there was a huge opportunity to do that before legalization or early into legalization. And I was very disappointed in the dearth of educational products and strategies that the government supported. And I think that leads to what Josh had mentioned earlier. This expectation that legalization means that you don't have to be concerned about harmful effects, and there's no ways of using it that are completely harm-free, but there are lower risk guidelines around use, and there was no education other than what the consortium has done, and Epion and Canada Schizophrenia Society. But the government itself could have done more because they're the ones legalizing it. So they're the ones that really need to say, okay, this is the education that you need to know.
So I think what I find frustrating the most right now is from my perspective, I've just started this position about a month and a half ago. So really been able to dive right in with early intervention in psychosis and schizophrenia and the cannabis stuff. And I was very surprised because outside of this area, I really hadn't heard much of any type of issue. Like, because I worked in healthcare, I knew there were issues out there, but I didn't know discussions were happening at this level with cannabis and psychosis. So I immediately thought to myself, why isn't this being talked about more on a broader level? Even with when it became legalized and all of the shops started popping up, I was very surprised. I mean, in my town, we have 3 LCBOs, 3 beer stores, and there's probably we're probably moving up to triple that amount in cannabis dispensaries. They seem to just be popping up everywhere. I've found it interesting that nobody that actually works in any of these places is any type of professional or expert on the subject. If you ask them about a product, all that they're allowed to speak to you about is the effects on them from what they've had experience trying. They can discuss what the various percentages mean, higher and lower, but I mean, I think the majority of people can kind of work those things out. So I think there should be, personally, I feel there should be some sort of responsibility at the level of sale to be providing some sort of education, whether it was either like a pamphlet that they throw in the bag with your product, just to get the stuff out there, because I really don't feel the majority of the public, will say, that are out and about really don't have much of an idea of all of the risks and effects that go along. Even with the various available types of product for consumption, drinks, gummies, other edibles, and what they do, what they mean, how they may affect you.
Right. No, I think it's really interesting, Josh, that you took it from that perspective, and Dr. Archie talking about it more from the government perspective, but really this lack of education or knowledge that's out there, from whether that be a frontline perspective or whether that be from the government, and really looking higher up. I think it really goes to illustrate that this is an issue that needs to be dealt with at multiple different levels to actually get the effect that we're looking for. And I'll pass it on to Dr. Herman as well to add any thoughts that you have in terms of other challenges, frustrations, opportunities that you see in your work.
I'm here. I've been sitting here trying to think of just a single frustration. I think what I'll raise that ties into what some of the others have said is what frustrates me is that from a systems level, psychosis and substance use or cannabis use continue to be treated separately in a lot of cases. So I'll see people bounce back and forth between psychosis services and addiction services. And addiction services will say, we don't have specialization in psychosis, we can't provide this treatment. And psychosis services might say substance use needs to be managed before we can provide treatment. And we know that people that have psychosis are much more likely to use substances. And I know there's likely a chicken or egg thing there, and that substance use, as we've talked about, can increase risk of psychosis, but also substance use can help folks with psychosis manage symptoms or work in other ways for them. So we do see, over 50% at times of folks entering first episode psychosis programs use substances, and yet we're still not treating them as one presentation, as one person that has, what am I trying to say here? That substance use and psychosis are so linked, and yet we tend to still treat them. And that frustrates me. I think that every clinician who's working in a psychosis program should have some training in substance, even if it's someone like me coming in for a half day, or a full day, providing some education. But I see often clinicians not feeling like they have the capacity, the training, the knowledge to work with their clients around their substance use. And yes, it's such a big part of their presentation. And so that continues to frustrate.
And maybe just building on what Josh had said earlier about, the concentration of, cannabis retailers. And, the study that Kelly Anderson has done, showing that areas where people experience more social marginalization, have more social disparities and inequities, these are the places where the cannabis retailers are the most concentrated. And then on top of that, higher service use for psychosis. And, so these stores are, I guess, making inequities could be contributing more to inequities in certain areas, but how is that then leading to more resources for services? So, you know, is the taxation, is it going back to actually increase the number of substance use programs, early intervention and psychosis programs? Like, I think these are really important questions now that we need to raise with the government. Yeah, the government is taking in more taxation, but are they actually providing more services? Now we know that the service use is increasing because of the retail concentration of cannabis stores.
No, it's really interesting. I mean, just the idea of perpetuating inequities, and just like you put Dr. Archie thinking about, are the services being provided, but also are the right services being provided? Like Dr. Herman mentioned, of often things are so siloed within different facets of the healthcare system that it's hard for people that are even trying to reach out for services to get supports. And you might not find services that are integrated in smaller areas or areas that have, you know, larger amounts of inequity compared to some of the larger city centers where it may not be possible for people to come in the first place. So I think it's really interesting to think about what inequities versus what inequities are being you know, furthered, and what are the resources that are being provided to these individuals as well. I know we're just rounding up around the hour right now, and so I wanted to just take a minute to ask everyone to, maybe we can go around. Any key takeaways that you want to reiterate from something you mentioned before? Anything you think we haven't touched on in the topic and the conversation that you'd love for the viewers to hear or to know more about? I won't pick on someone because I know it might take folks a minute or so to think about it. But if you have any thoughts, would love to maybe start there, and we can go around to hear.
I might start, Hargan, just because I was thinking about something that everybody is sort of focused on, and what we've mentioned in a number of different of these conversations, and that's based around education, right? Such a key component for us to have that knowledge translation of research and get that education out there. But you know, I do want to underscore how important that is, but also that what we haven't talked about is that, you know, when we develop this education, or we get this out to the community, it still has to be focused and, you know, to the group that the target audience is, right? So if we are focusing education to youth and young adults, then it's youth and young adults who should be involved in the development of that education, because it has to resonate with them, right? You know, when we're talking about equity deserving groups and you know, getting the education to them, well, they should be involved in that education. We should know how to get that out to them. So we have to be careful, not just a blanket statement of education, but also, you know, okay, who are our groups, and who do we want to get them to, and how do we involve them in the development of those education products, so it resonates and has a bigger impact. So that's just one thing I just wanted to come back to and reiterate.
I think that's so important. I know at the Schizophrenia Society and the Cannabis and Mental Health Project, a lot of our work is produced by youth for youth, and it really makes such a big difference to see youth that are speaking in the videos that you're watching. Even using the language is something that I've noticed has really resonated with other folks, and moving away from some of the scientific knowledge we see to knowledge that's more used in common conversation that you have. And so I think that's such a great point, and so important in making the education that we share stick. Pass it on to anyone else who may have a thought in mind.
I'm just really thinking about what Suzanne said about the taxation. I think that's a very, very important thing. With the amount of revenue that the government is taking in off of this new taxation, it would be very interesting, and I think it'd be very important to see how much of that is being put back into services, education, any of that type of thing for early psychosis, or any of the services that have to do with any of that. Because as I was thinking about it, being front line, what we hope to do is be successful in helping somebody become get to where they want to be, live the life they want to lead. That's what we hope to do. Unfortunately, we're not always successful. If somebody goes down the road and unfortunately isn't successful, that then leads to potential repeat hospitalizations, potential problems with the law, a whole uh, line of things could take place that then add to the weight on our resources. The more people that if we get, or have issues, um, eh, higher rate of hospitalization, less beds. Same with if you have higher arrests, um, higher prison population because of it. Like any little bits don't seem like little bits within their own thing, but when you add them to the rest, it creates more of a problem. And if we're not getting the funding, which always seems to be an issue, to put back into these resources, um, everybody's just struggling.
Yeah, and to just build on that, in some ways, it is a little bit of a conflict of interest with respect to the government. So here now they've legalized a substance, they're getting taxation from it. They become the government becomes dependent upon this new source of taxation. So the conflict of interest then is, well, if this is a good line of taxation that people are doing, then why would we put in services to reduce the amount of use that goes in? And sometimes we don't sort of think about it from that perspective.
No, I think that's such a great point about some of the conflicts that exist. And Joss, like you mentioned, how do we fund the resources that are required? And Dr. Thibault touched on it earlier, even the research and how some of the funding is really running out or not as intensive as the first couple of years. I think it's so important to think about where is this money going and how can we work through it in a way that is objective without some of these conflicts, which may not be possible at the end of the day. So really, really great points to be brought up as well. Dr. Herman, anything to add or any other points you wanted to bring up?
Nothing to add. I guess if I was going to have one takeaway for people that might be watching this, whether it's people who've experienced psychosis, but more so clinicians, family members, community members, is just to show up with curiosity and compassion and open-heartedness. These are some of the most wonderful people I've ever worked with in my life. And yeah, just that we all show up as we have here today. It's been a pleasure talking with all of you. I want to talk with you all a lot more. Thank you.
Thanks so much, Dr. Herman. I think that's such a great way to end the conversation as well, as there's really showing up with compassion and curiosity and how that can go such a long way in the interactions that you'll have with others within the healthcare system, within different social services on the front lines as well. And so just want to wrap up by saying I think we've covered so much in this conversation, from cannabis use, its relation to psychosis, ways to lower your risk if you're using cannabis, schizophrenia and psychosis and the stigma and how that's really combated and what that looks like in different settings, and so much more. And I've certainly had such a pleasure to be able to take a back seat and just listen to all the expertise that everyone's bringing here. But really want to thank everyone, Dr. Herman, Dr. Archie, Dr. Thibault, and Josh, for sharing your perspectives, bringing your knowledge, and being so generous with the time that you've given us. I'm sure it'll be as valuable to the viewers as it was to me and to others watching to hear these perspectives and learn about everything that you have to offer. And so again, thank you so much. It's been a pleasure, and really enjoyed having this conversation with everyone here.
Great, thank you.
Thank you.
Thank you very much.